colleagues. Thank you, Dr. A few slides. And what I'll be sharing with you, I'll make a bit of references to the Kenya Mental Health Investment Case 2020, which is a study undertaken in this country by multiple partners, trying to see how we can build a case on issues of mental health. But today I will talk about it, make a reference to it in the context of mental health programming. In my presentation also, I would wish to share with you information in a very brief manner. It's for you to try and synthesize this information and probably make some reflection on this concept of mental health at work. Fact I would want to share with you is that decent work is good for mental health. When we think about work, and this is something I would want you to reflect from all aspects about human psychology, is beyond people getting an income, a livelihood from work. Work forms a part of our social life. We generate some social capital by working. We generate a purpose and meaning in life by being at work. And I would wish, as you think about that, try to think about what does it then mean to the human being in terms of the human psychology, from whatever perspective you would want to look at this, from the psychoanalytic to issues of even the neuroscience of a human being. Contrary, a poor working environment is a major risk to the mental health of a human being. And this comes from that, as I say, work is good for mental health. If that workspace is not conducive, then it becomes a hazard to the human mental health. I'll give some few figures that 15% of the working adults were estimated to have a mental health condition by WHO 2019 report. That's a big number. And probably these were people with a diagnosable mental condition. Because when we talk about mental conditions and mental health, we are talking of a spectrum, a continuum. So probably you'd do your mathematics, what could have been the other number who had mental health problems ranging from daily mental distress to potentially distracting mental health problems at the workplace. When you come to the economic analysis, globally, an estimated 12 billion working days are lost every year to depression and anxiety. Mainly only those two conditions, which cost about US dollars 1 trillion per year lost productivity. So that's the background in terms of the facts, and what is trying to bring to our focus is how important work is in terms of mental health and how the workspace should be our area of focus and programming if we are to achieve the various visions we have within our mental health programming. Now, let me try to draw some references from this study. There's a study we conducted in this country called Kenya Mental Health Investment Case, the year 2020. And we were trying to look at the long-term health and socioeconomic benefit on investing in mental health. This is a booklet, and you can get more of this from our website, mental.health.go.ke. So this study included both a situational analysis and economic analysis. We had mental health professionals, we had health economics doing these investigations. And the methods were trying to determine the total cost and the expected health and economic benefits. by undertaking implementation of clinical and population-based mental health interventions. They were actually focusing on 6 common mental conditions. These were depression, anxiety, psychosis, bipolar, alcohol use disorder, and neuropsychiatric condition, epilepsy. And then there were 2 health interventions. That is a ban on pesticides and implementation of a school-based socio-emotional training skills, and trying to see between a period of 10 to 20 years, what could be the cost and what could be the returns of the investment. So basically, they worked to estimate the economic burden attributable to those mental health conditions in terms of what we call the direct cost and the indirect cost. Let me emphasize the indirect cost because it's what is of our importance here in our discussion today. The indirect cost was to look at in terms of productivity losses due to absenteeism, presenteeism, and premature death. Or you would look at it the other way around. If you were to implement this, not only trying to reduce these indirect costs, what are the gains in terms of the preventable premature deaths, the healthy lives added to people's life, and the productivity which comes from that? Vis-a-vis, what is the cost of intervention? And now once you get the 2, you get what is the cost of the intervention, what is the burden. You use this model to calculate what we call the impact in terms of looking at the returns of investment. Still trying to share with you on this method. They used a tool called One Health tool. Was used to estimate cost arising from several clinical interventions for the 6 conditions I mentioned: depression, anxiety, psychosis, bipolar, epilepsy, and alcohol use disorder. Then they used a custom-built Excel model to estimate the costs associated with the following population-based mental health intervention: a nationwide regulatory ban on highly hazardous pesticides to prevent suicide, and universal delivery of socio-emotional learning programs to adolescents in school. So each of these interventions was modeled using that tool, those 2 tools, with contained assumption made from the WHO experts about the quantity of resources required for implementation and enforcement at the national level, in line with the methodological guidance for mental health investment. So there's a lot of modeling and calculations done from assumptions done, and to see what would it cost to implement this program over a period of 10 years and 20 years. And then you get to know what will be the benefits derived from that. So from the results, and what is very important for us here today is to see what they found out. They found that majority of the burden in terms of mental health conditions at the workplace was as a result of the indirect cost. Let me explain this. They found 49% of the burden was due to absenteeism. These are people who have a mental health conditions, but they are not present at work. So that is a lost productive. Those are healthy working years also lost. They also found that 30% of the burden are due to what we call presenteeism. These are people who were at work, but they were not productive enough due to either undiagnosed or mental health issues they were going through, probably they didn't know about because of issues of mental health literacy and stigma and all those kind of things. Then 12% of the burden was due to losses due to premature death. So here they try to calculate what is expected life expectancy and the total year lost due to the burden of mental illness. And then they will say you have had premature death and all that. Seeing something funny on here. Say no. My computer. It's okay. Surprisingly, only 9% of the burden was due to direct costs. Direct cost is the cost when someone is unwell, which is due to the treatment which happened to the hospital and all those kind of things. It would only account for 9%. So the indirect cost is the major burden when someone is going through a mental health condition. And here I'm trying to build a case to see why is it important to do this mental health programming. Don't know whether you can see from that. It's so this is like a general summary of the burden was 62 Kenyan shillings, 62.2 billion Kenyan shillings. 90% was direct cost. Only 10% was due to the direct cost. When I mean direct cost means the cost which goes to taking the person to hospital, getting them medication, and all that goes into that. There is usually the silent cost we never see as a burden. And this is what we are trying to address in this programming. Then they looked at, if we are to reverse this, then we need some investment. And for us to talk to the people who give money, we must be able to put a case to say, you put this money, and these are the returns over 10 years, over 20 years, and then you can be able to convince them that it's worth it to put money in mental health. And they saw Kenya shillings 1,717 per capita. And they looked at the different interventions and the conditions they were treating, and they had the different. So one thing which came out is the conditions like bipolar and psychosis were more costly to treat, investment required, compared like anxiety and depression. And surprisingly, even alcohol use disorder has a less cost in terms of what the amount you put. And there is an explanation of psychosis and bipolar, why they were, I think they are the ones around 13, 13.2. You can see the figures. You can see the others are 3.7, 4.2, 2.2. You can only see huge figures of 13.2, 32, and 13. The others were less than 10. Look at those figures. Whatever the then you can be able to calculate. And then after that now is when they were like to see what were healthy life years gained, what was the productivity gained, how did they manage to reduce the premature death. So they get the gains they get from that versus the cost, and then you calculate the returns. And the returns were done in different ways. They did over 10 years and 20 years because we needed to convince them. Yes, probably the returns will be lower in 10 years, but in 20 years, the return even get huge. And so here, that's where the returns were. Maybe you can see where some areas which gave some of the best returns was investing in treating depression, investing in treating anxiety, investing in treating alcohol use disorder. The returns were huge. They had, you can see where but the figures were above the others. And also an investment on the ban of pesticides and a school intervention on social emotional learning skills showed major investment, especially 10 to 20 years. Especially that you don't look at 10 years because these are kids you are investing on them in terms of adolescence, and you are looking at them in 20 years. So why have I given all this? I'm trying to get you a psychiatrist where you're working at institutional level, you're working probably as a teacher, you're working as a researcher, to see that I need to win you to get into this mental health programming at the workplace. First, I've talked about what segment of the population is at work. The majority of the population. What are the returns we get in case we invest in some of these conditions in terms of the socioeconomic impact? And at work, we are there to see those kind of impact. We are business oriented. We want to see business results. And so a condition like someone who is using alcohol at the workplace, some of the institutions may think about relieving this person of work rather than thinking if we invest, the returns be huge. So as a ministry and within our policy, this is a key area of focus, and you're working on guidelines. We'll be launching them very soon. And it's also an area of interest in the WHO programming. And our guidelines will be trying to provide evidence-based action on how we can prevent mental health risk at work. So prevention. The second is how to protect and promote mental health at work. How we can support and care for workers with mental health problems. My focus here is not on the mental health condition, across the whole continuum. To guide institutions on how they can develop a policy on system and structures for them to implement awareness program at their work. That's another key provision within this document. We'll also provide within the document a framework on how to evaluate the effectiveness, provide continuous learning, and improvement of the program. And lastly, also to have institutions be able to adapt to the changing work environment and emerging issues. So this is a guideline we are working on. Probably very soon we'll be sharing with you when it's officially launched. And with this kind of information, we want to get you on board in this journey of mental health programming at work, because in the current dynamics in terms of our global way of living is the way to go. I decided also I share with you modern workspace and emerging issues. If you realize this guideline focus will be guided with the modern workspace and emerging issues. Note, I'm not talking about the workplace, because the work now has gone beyond a place, a limited location. And these are issues I would want you to reflect on and try to see as you move to this area, that digital technology is now providing virtual and hybrid working space. So when we are talking about work, we are no longer going the traditional workspace. There is also a lot of technological automation in the workspace. There are many things we are doing through automated processes. There is also the artificial intelligence and machine learning. What it means, there are machines through digital technology can do as well as probably as human being can do, sometimes even better. And what does it mean to the current working space? There are issues of diversity, equity, and inclusion, what we normally refer as DEI. What does it mean within our workspace today? Work-life balance is a concept of workplace wellness. Globalization and collaboration. We're no longer working within a limited space. We are working within multi-center in a global arena when you're working. You could be here and you're working with someone in Japan. That is still a form of workspace. More importantly, from the traditional aspect of looking at the academics and work experience, we are moving to a workspace which is highly appreciating your skill sets, creativity, and solution. So what does that mean when now we are having people in school and we are getting them to the workspace, which no longer just look at the academic paper? They want to see how much creativity and solutions and the skill sets you have beyond your academic paper. And more recently, now we are talking about climate change and work, the green environment. I know recently we had the summit, you had us talk about the carbon assets, the carbon tax, and that's the environment. But also how traditionally we know the climate change is affecting the socioeconomic aspect of our life and how that goes to the place of work. So these are things we have put a lot of thoughts in this programming and the guideline. And as you join us in this work, probably there are areas you need to think of. I think that's the last slide. In this investment case I've referred to, I need to acknowledge some of the key partners who are involved. The Ministry of Health was the lead. We also had the US Interagency Task Force on NCDs, World Health Organization, the UNDP, and a team of multidisciplinary experts working around this. And lastly, these are some of the documents Marcy mentioned we are working on, and all this work is derived from here. See the second document is the WHO guideline on mental health at work, and that is an evidence of the sharp focus on the issues of mental health at work. So why have I presented this? Traditionally, as a psychiatrist, whether we are working research in the clinical area, we were thought that probably our work is to either to train psychiatrists, is to do research in psychiatry, is to do practice. But we need maybe to have a paradigm shift towards aspect of preventive and promotive programming, because that's where we are now in the world. And probably I hope this would generate some interest in you to start looking at some of these issues. So I think with that, thank you for your audience. Probably as we move on, Marcy will tell me whether I have any questions to clarify or maybe to answer. Thank you.